Professor Karen Harrington from the Institute of Cancer Research in London. I think, Karen, you have been here 3 times already?
Yes.
So you just missed one. So you must like Zurich somehow, right?
I absolutely love Zurich, and I'm very grateful again to Ralph, to Michael, to Kathleen, and all the organisers for the chance to come back and to what I think is a highlight of the year for me, this symposium, which is excellent. I feel a bit like a poor relative, actually, in comparison to the melanoma and lung doctors when I'm going to present to you on head and neck. You have an embarrassment of riches of data. We are at the beginning of defining the role of immune checkpoint inhibitors in head and neck cancer. And so what I'd like to do today is to share with you new data that has emerged within the last 12 months, which has changed practice. And I will hint at the fact there are ongoing studies, which I hope will follow in the footsteps of other tumor types, including melanoma and lung cancer, to continue to push back the frontiers and to improve outcomes for patients with head and neck cancer. These are my disclosures. So the big news in head and neck cancer, if you missed it and you're not a head and neck doctor, is that there was a readout of the primary endpoints of KEYNOTE-048, presented at ESMO last year and updated at ASCO earlier this year. And essentially this was a study looking at the role of pembrolizumab in combination with chemotherapy, or as a single agent versus standard of care chemotherapy in the so-called extreme regimen, which comprises platinum, 5-fluorouracil, and cetuximab. And the primary analysis at the interim analysis 2, so the data presented at ESMO, demonstrated surprisingly that pembrolizumab had defeated the extreme regimen, which I think was not the expectation when the study was designed. The expectation was maybe pembro chemo would be the winner, and the pembro arm was really in there speculatively hoping for a positive result, but I'll show you the data. But the output was a significant improvement in overall survival at the CPS level, and the combined pathological score greater than 20 and greater than 1. And it was reported as non-inferior in the overall population, and I'll show you an update of those data. The pembro chemo combination was reported last year at ESMO, but only for the total population, and again showed a win. Pembro chemo had defeated the extreme regimen, but I'll show you some data that really suggests that maybe there's a group of population of patients best treated with single-agent pembrolizumab. So this was the design of that clinical trial. You can see it's for patients with relapsed head and neck cancer. This is in the first-line setting, so for patients who had not received prior cytotoxic chemotherapy in relapse. You can see for relatively good performance status patients, and we needed to know the P16 status to define HPV positivity or negativity for patients with oropharyngeal cancers. You can see the stratification was around high PD-L1 expression at a TPS of 50 or greater, and as I've already told you about the HPV and the ECOG status. You can see the design of the study, a 3-arm 1-to-1-to-1 randomization, and I want to emphasize the fact that the study is not powered to compare pembrolizumab versus pembro chemo. The combination is only against the extreme regimen. The extreme regimen being the standard of care, as you can see there, with the option of maintenance cetuximab. For the groups of patients receiving pembrolizumab, they could receive treatment for up to 35 cycles, so for about 2 years of therapy. These are the primary endpoints of the study, and so the initial analyses for overall survival and progression-free survival were defined around the CPS of greater than or equal to 20, the CPS greater than or equal to 1, and the total population of patients. And you can read for yourselves the secondary endpoints and a number of key exploratory endpoints, which will now emerge over the coming years. I have to admit, this is without doubt the most statistically complex trial I've ever been involved in. So you can see here, this is the statistical analysis plan on how the alpha was spent during this study. Essentially what was done was that there were 6 parallel comparisons, and only if the first comparison in the hierarchy was positive could the subsequent downstream statistical analyses been done by handing on some of the alpha to those. So the boxes that are outlined in pink are analyses that have not been subjected to statistical analysis formally because the analysis above them was negative. The ones that are in brown and in blue are the analyses that were presented as an update. Now, I want to just draw your attention to this symbol here, these symbols here. Anything with a plus indicates that this was the first time the data were reported at ASCO, and anything with those arrows indicated that the data I show you are an update of the original ESMO presentation. It was a big study, one of the biggest studies completed in patients with head and neck cancer. We don't have the same sort of recruitment rates necessarily as melanoma and maybe some of the lung cancer studies, but a big study nonetheless. Over 800 patients randomized into this study. And the patients were balanced across the main important prognostic and statistical analysis plan variables. So the first data set I want to show you is the fact that the combination of pembrolizumab with chemotherapy has defeated standard of care extreme regimen chemotherapy. And this is the overall survival data, and the plus signal indicating that this was the first time the data was shown was at ASCO about 2 months ago. And you can see here that for the CPS greater than 20 population, the combination of pembrolizumab and chemotherapy was better than extreme, extreme being the E. And you can see there the improvement in median survival, and you can see the p-value, very healthily statistically positive. So about a 3-month improvement in median overall survival for this group of patients. And again, for the CPS greater than 1 population, again, evidence that there was benefit. And again, you can see that the p-value is indicative of a strongly improved outcome for patients receiving the pembrolizumab chemotherapy combination. And if you look across on these forest plots across all of the various indicators and all of the various categorizations, you can see that broadly speaking, there is no group of patients that is not doing better when you add pembrolizumab to chemotherapy in these analyses, either at CPS 20 or CPS 1. And encouragingly, the benefit seems to be particularly good for the patients who are HPV positive, but I draw your attention to the fact that the numbers of patients in that group are relatively small because this study was recruited in the main outside the USA, where the HPV positive populations are a little bit smaller. Here are the data on the progression-free survival. And you can see here that essentially the curves overlie one another to the median, and then they separate beyond the median. And I think, as Rolf very nicely pointed out in the lung cancer data, these PFS curves do not show a detriment to the immune therapy arm when you combine it with chemotherapy. And I'll contrast that with data I'm going to show you in a minute. Now, I just want you to bear this in mind. Don't be seduced by what looks like a very nice low p-value. The statistical analysis plan demanded that for this analysis to be declared positive, the p-value had to be less than 0.0017. So this is not a positive study in terms of progression-free survival at either of the CPS values. In terms of the responses, if you compare pembro chemo versus extreme regimen, the response rates essentially look the same, maybe a little bit bigger for the CPS greater than 20 for the pembro chemo combination. And in terms of duration of response, which is the main reason for showing you this slide, I want you just to fix in your minds the fact that there is an improvement in the median duration of response and the shape of those curves, and I'm going to contrast them in a moment with the single-agent pembrolizumab data and ask some questions that I don't have the answer to. But you can see for CPS 20 and CPS 1, if you respond, you have a good median duration of response that exceeds that seen with chemotherapy, and the data for extreme mapped very well to the original publication in New England Journal from a decade ago from Jan Vermorken and looked the same, basically. Now, this is an update, the little arrow signal, indicating the difference in the total population. This is the intention to treat population, and you can see here that the hazard ratio has now tightened a little bit to 0.72 compared to the original analysis, a significant benefit for patients. Notice the absence of a p-value up there, and that's simply because the p-value was stated in the time of the original analysis, and the test has not been repeated because it's already been found formally to be statistically significant. significant. These data were the basis for the FDA approving the pembrolizumab chemotherapy combination for the intention to treat all-comer population in the first-line setting, and that approval came in June of 2019 and is now operating in the US, and we await it in Europe, and I suspect sometime later than that in the United Kingdom, if at all. So in terms of progression-free survival, again, you can see here that there is no difference between these curves. And this is again, indicative of what we see sometimes with pembrolizumab in head and neck cancer. In terms of response summary, this is the total population, again, looking at median progression-free survival. And again, as I've asked you, this is for the total population to fix in your minds the shape of this curve and the median value of around 7 months. The toxicity of combining chemotherapy with pembrolizumab in head and neck patients, and I'm sure this mirrors what you found, Rolf, in lung cancer, is essentially the same as the toxicity of the chemotherapy itself. You can see for the patients treated with pembrolizumab plus chemotherapy, the overall height of the bars and the types of grade 1 to 3 and 1 to 2 and 3 to 5 toxicities look the same. The only discrepancy here being the cetuximab-driven toxicities that are only present, of course, in the arm receiving cetuximab. The chemo-pembro combination did not receive cetuximab therapy. So that sets the standard for a new standard of care in first-line setting for patients with relapsed head and neck cancer. What about the pembrolizumab monotherapy arm? And this is the comparison here. Again, I emphasize there is no pembro versus pembro chemo formal statistical comparison. So here you see new data in ASCO, the overall survival population. And I want to just emphasize this, and we can discuss this perhaps, maybe a detriment in some patients receiving single-agent pembrolizumab. But you can see that overall, the hazard ratio is 0.83, and there is a p-value here that again may look seductive, but I want to draw your attention to the fact that the boundary for formal statistical significance for the total population of patients would have been significantly lower than that. So pembrolizumab has not beaten extreme regimen for all comers on overall survival. And again, there are concerns, I think, very real concerns that some patients who are randomized to single-agent pembrolizumab compared with effective cytotoxic chemotherapy may be getting a progression-free survival detriment. And I think I would echo your comments, Ralph. We do need to know who is safely treated with single-agent therapy because patients are doing worse here with immunotherapy on PFS grounds. Now, I asked you earlier to fix in your memories the shape of curves relating to duration of response. So first of all, I'm going to show you that the response rate to single-agent pembro is about half the rate to combination chemotherapy. But for those patients who enjoy a response, the duration of response is nearly 2 years as a median. Now, why there's a difference between single-agent pembro and pembro chemo in terms of median duration of response is a question I would love to hear the answer from the audience about, because it's a difficult one to think about. If we look at the overall survival data now, and these are updates of the ESMO data, you can see for the CPS 20 population, again, you don't see a p-value because it's already been found to be statistically significant at the time of the IA2, the interim analysis 2 at ESMO. You can see that there is an improvement of 4 months in median overall survival at CPS greater than 20. And at CPS greater than 1, which is what the FDA approved in the United States, and I suspect that this may be what the EMA approves and certainly what NICE may think about paying for in the UK. But at the CPS greater than 1 approved in the USA, you can see here that there's about a 2-month improvement in median overall survival, but a healthy tail on the curve indicative of benefit to these patients. In terms of progression-free survival, and again, this is for the various CPS groups. Again, I just draw your attention to that, but I point out the fact that there is no statistical significant difference between these, but there's potentially a detriment at the median for the patients receiving single-agent therapy. And again, when we look at the various CPS groups, you can see that the median duration of response is approaching 2 years for patients who get a response to single-agent pembrolizumab, and that is significantly better than extreme. The toxicity is markedly improved for this group of patients, so it doesn't look like extreme toxicity. And of course, for patients who don't have bulky disease and who have the time to get a response to immunotherapy, especially if they've got a CPS greater than 20, I think there's a very strong reason for thinking about single-agent pembrolizumab, not least of all because you spare patients toxicity, and if they get a response, that duration of response may be very prolonged indeed. So these are the summaries of the various statistical analyses, and I've tried to point them out as we go. But to summarize, FDA has approved the pembro-chemo combination for the totality of patients with relapsed metastatic head and neck cancer in the first line, and has also approved pembrolizumab at a CPS greater than or equal to 1 for that same group of patients, leaving it to the clinician's discretion to decide when to use cytotoxic chemotherapy. So from the positive, I now want to dwell on some negatives because it's important to recognize, and this isn't just a segue, these are 2 trials, the CONDOR trial and the EAGLE trial, CONDOR on the left, EAGLE on the right. So these have read out in the last year. The CONDOR trial and the EAGLE trial, so these imaginatively named trials are from the RAPTOR series, so-called, named by AstraZeneca, I think, to be aggressive birds of prey, preying on head and neck cancer. And unfortunately, those studies have landed this year, but they've rather crash-landed rather than making a glorious landing. So the first study, and apologies to anyone from AstraZeneca in the room for that bad joke, the CONDOR study was a phase 2 study, randomized, looking at the addition, and we've already heard of this from both of the other presentations so far, of tremelimumab, an anti-CTLA-4 drug, to the anti-PD-L1 drug, DURVALUMAB. And you can see the randomization there, 2 to 1 to 1, a total of 267 patients. And I summarize for you there the overall response rate, which was the primary endpoint of this study, indicating, curiously, that the PD-L1 drug gives a response rate which is less than what you see with PD-1 inhibitors. For nivolumab, it's about 14% in head and neck cancer. For Pembro, it may be as high as 15 to 16%. So Durva looks a little bit lower, albeit in a relatively small group of patients. Tremelimumab really doesn't work in this group of patients. So CTLA-4 blockade doesn't work in head and neck cancer, at least in this setting. And this is a group of patients with so-called PD-L1 low tumors, although the cut point there was PD-L1 less than 25% on this analysis. But the really curious thing to me is, why does Durva plus Tremi do worse than Durva single agent? Now, of course, it may be a statistical quirk, or there may actually be something going on biologically here. So that leads us to EAGLE that read out at ASCO 2 months ago. And this was the randomized component, and now this is, again, second-line treatment, not first-line treatment, this is second-line treatment. So this is the setting in which pembrolizumab and nivolumab have already definitively shown that they are better than standard of care physician's choice chemotherapy, and you can see in the green box the range of chemotherapies that physicians had at their disposal to treat their patients. So Durva plus Tremi, 4 doses of Tremi, relatively low-dose Tremi to try to avoid toxicity in our group of patients versus Durva. And you can see that this is about a 750-patient study. Primary endpoints, as you can see, overall survival. And again, no direct comparison allowed between Durva-Tremi versus Durva. The study's not powered for that. The comparison is at the level of standard of care chemotherapy. And this is the disappointing output of this study. So in line with the CONDOR study, the EAGLE study has also crash-landed, demonstrating standard of care chemotherapy is as good as Durva plus Tremi and as good as Durva. And indeed, the addition of Tremi is doing nothing in this situation, other than perhaps adding toxicity. If the patient gets a response, and of course, this is a post hoc analysis, not originally scheduled, but to try to extract some positivity or some message from the data, and the investigators have done a good job here. And I draw your attention to these curves over here. Those ones to the right-hand side are what happens to a patient if they got a response to treatment. So if the patient had a response to durvalumab, and the response there is about 40 plus patients who had a response, that response is good and durable, in line with what we've seen with other immune checkpoint inhibitors. If they have a response to durva-tremi, it's also durable, but it's actually less than durva single agent, which again to me is curious and needs some thought. And for patients who get a response to standard of care, we know it doesn't last very long in patients with head and neck cancer. In terms of whether or not EAGLE met its endpoints, you can see here that on both of the analyses, durva single agent, durva plus tremi, it was a negative study. And I've just shown you the data there just to summarize the median overall survival data from the Checkmate 141 and the Keynote 040 data that have already been published that establish the standard of care. So in the last minute or two of the talk, I want to present some data which I think are underpinning a new phase 3 study that will activate within the course of the next 6 months, we hope. And these are data that were presented by Ezra Cohen at ESMO last year and haven't yet been updated, but will be updated and will be published. But these data as yet are formally unpublished. And this is looking at the question of what could we do to make an anti-PD-L1 drug like durvalumab work better. And it was based around the premise that some of the inactivity of anti-PD-L1 therapies is based around the intensely immunosuppressive microenvironment existing within head and neck cancers. And that is driven in a large part through a very prominent population of myeloid-derived suppressor cells. And so the hypothesis here was that two different therapeutics, a drug AZD9150, which they think is going to be a drug, which is why they've given it a name and is now called danvatirsen, which is an antisense oligonucleotide that prevents activity of STAT3, or a small molecule inhibitor, AZD5069, which is an anti-CX2 drug that is aimed at preventing myeloid-derived suppressor cells exiting the bone marrow and finding their way to the tumor where they can mediate their immune suppressive effects. So these are just some data demonstrating the proof of principle for these agents. So I don't need to tell you anything about PD-L1 or PD-1 inhibition, but for STAT3, we know that STAT3 is one of the master signal transduction pathways involved in mediating immune suppression within the tumor microenvironment. And here are data showing that when you add in a mouse model, CT26, which is an immunogenic tumor in mouse, you can see that the addition of danvatirsen to an anti-PD-L1 that works in mice gives an additional benefit over a relatively short period of time. And here you can see on the immunohistochemistry, you can see that the ASO, the antisense oligonucleotide, reduces the recruitment of myeloid-derived suppressor cells into these tumor deposits. So the SCORES study is a complex study, and these are the first 7 arms in the study, and I'm not going to go through it in detail, but what I am going to point out is the data that are presented largely relate to arm B3, which was the arm that combined the anti-STAT3 antisense oligonucleotide and durva. And this is the spider plot for those patients. So deep and durable responses in a large number of patients. You can see that the response rate is significantly greater than, although that's not a formal statistical test, is greater than for single agent durva, as I've already shown you earlier on. And you can see there summarized the data from CONDOR with a 9% response rate. So the combination of durva and danvatirsen appears particularly favorable. In arm B8, there is an ongoing study looking at combining this with the danvatirsen given on a 2-weekly regimen to make it more convenient, the durvalumab given on a 4-weekly regimen, and this is going to a formal phase 3 clinical trial. And I want to just show you some biomarker data that indicate that the drug is acting in the way that we think it should be acting. And these relate to what happens to a suppressive signature. And you can see what is being used as suppressive signature. And this is from the small number of patients who give those very precious samples, the pre-treatment and the on-treatment biopsy, for us to be able to show what's happening. And you can see this is the definition of what we're calling a suppressive signature, an interferon gamma and a type 1 interferon signature here. And the hypothesis being that if we can suppress the effects of these cells on suppressing cytotoxic T lymphocytes, maybe we'll get better therapeutic outcomes for our patients. And these are data, albeit based on only 8 patients in that 20-patient cohort, but nonetheless, I think, provocative, demonstrating that for patients who had good responses, we saw changes in the suppressive signal when they were receiving danvatirsen, the anti-STAT3 drug, whereas for patients who did not get responses, we didn't see any changes in those suppressive signatures. And part B8 of the study has mandated biopsies before and after, and we'll have a whole new data set in order to address this issue. We don't have data for single-agent Durva, and we've had to use lung cancer control data where we don't see the same phenomena as the control in that situation. So in the time allotted, and I thank you for your attention, I hope I've shown you new data indicating changes of standard of care in the first-line setting, some hints as to what might be coming for other agents to modulate the activities of PD-1 and PD-L1, and I've shown you that not everything that takes off lands well in the form of the birds of prey. Thank you very much.
Thank you very much for very clear statements. Could you make a statement about HPV? Is HPV increasing the effectiveness of immunotherapy or not? There was no hint in your talk about that aspect.
Yeah, I deliberately avoided that as an issue. HPV is not a selection biomarker, should not be used as a predictive biomarker. I think the suggestion is in the first-line setting that patients with HPV-positive disease are more likely to do well, especially when given single-agent pembrolizumab. In the second-line setting, as you know, the data are slightly conflicting. Some studies show it does really well in the HPV-positive population. Other studies show that it does really well in the HPV-negative population. We could argue or we could discuss whether or not that relates to tumor mutational burden and the different flavors of mutations you see. But broadly speaking, you should not use P16 status or HPV status as a reason for giving or withholding immunotherapy for patients with head and neck cancer. And I wouldn't use it as a reason for using the combination with chemotherapy versus single-agent Pembro in either direction. We don't have those data yet.
You have shown a lot of these data on the smaller responder subgroups. What's your gut feeling? Are any of these patients cured? It's early days, but...
Yeah, it is early days. We're having the same experience now. We've got patients coming to the end of 2 years discontinuing medication in line with study protocol, trial protocol, and we're seeing relapses now. Having said that, we're fortunate enough in the KEYNOTE-040 study to have a patient who is now 4.5 years out from treatment, and to the best of my knowledge is the longest lived survivor on that phase 3 study that included, nearly over 500 patients. So I think it's a rare event, but I'm touching wood that that gentleman is cured of his disease, but he's a small subset, to say the least. For the patients in the phase 3 KEYNOTE-048 study, it's far too early to say. I think we may cure a very, very small population of patients, and I think that we will see relapses occurring. Interestingly, of the patients who have relapsed and who have then been able to go back onto immunotherapy, we've seen re-responses, which is really encouraging, which of course begs the question, should you treat for 1.5 years, 2 years, stop, wait to see if a recurrence occurs, and then re-challenge? I think the feeling is maybe the patients don't do as well as if you maintain them permanently, but certainly our healthcare system will not be able to treat people indefinitely on immune therapy, not unless the price comes down.
Okay, thank you very much.
Thank you.